So hello everyone. I'm glad to welcome you all today at our 3D Predict Study Night event in Richmond. And we're, as you might know already, some of you, we're a liner company that makes complex things easier for orthodontists. My name is Sasha and I'm a technology consultant at 3D Predict. Please feel free to scan the code if you'd like to schedule a demo call with me so we can talk about various clinical cases and I can tell you more about the company. So what makes us different? First of all, our AI technology that makes our biomechanics stellar, which means that thanks to our AI that learned from various clinical cases with less refinements than you usually might have as an orthodontist. So hence we have this elaborated technology that help you to spend more time on things that make sense to you rather than unnecessary refinements. The point here is, as you know, you have your orthodontic eye and sometimes you need a refinement. You think that patient needs a refinement, but what we do in here is we are helping to avoid unnecessary refinements. So our technology in the partnership with Google, our clinical team of orthodontists were reviewing and designing the plans. So you can rest assured that you will get the most predictable result as possible on the market with other liner systems. So how to utilize our AI technology? With us, you can have two different 3D plans. First is crown-based model and deep CBCT model. So how are you going to get the predictable result with both of them? Crown-based model is predictable and effective to one main reason. We taught our AI on clinical cases that had deep CBCT model where you can see root and bone. So our AI learned how to distinguish root from bone. So now we're able to introduce you very precise crown-based model thanks to our AI technology. So even if you don't have CBCT or you choosing not to use CBCT for a case, you can rest assured that you will have the best possible outcome with us. If you're choosing to have CBCT scan for the patient, you're submitting this to receive two different models. The heat map on the bone model on the left side, which shows the thickness of the cortical plate and how it's changing throughout the treatment. And on the right side, the example of the root model, when you can see the shape and the size of the roots, and hence you're able to see the patient's anatomy. So you can apply forces in a more precise, predictable way to be sure that the result you see at the last step of the plan is actually matching your expectations. So once again, AI makes it possible to just have crown-based plan, and the clinical cases with other systems, they basically have 3, 4, 5 refinements. So that's why technology learning from these cases, and you get the the relevant results. So we did set multiple parameters that helps us to calculate how to apply forces, how to combine movements. So it's going to be shorter and you will have maximum 6 ortho appointments and you can utilize your time in a more efficient way. Once again, this is just another example of the root model in our deep CBCT analysis. What sets apart 3D Predict is how we use in deep CBCT scans. With us, you can be sure that if we see that the roots are going to collide, we will never offer you the treatment plan with roots colliding. we're going to offer you analysis on how to circumnavigate these clinical obstacles for each specific patient. And this is just the example. You can see the predictability for different cases. I'm not going to repeat this. It's self-explanatory. With us, you can have a predictable result. You can have less refinements. It will save your time. Your patients will be happier. As you can see, the bone model that we were talking about on the previous slide shows us the distance, the thickness of the cortical plate. If it shows red, it means it's really thin, and the blue is it means the distance is bigger. So you can assess the treatment plan from first to the last step, and be sure that your patient is safe and the treatment is efficient with us. We're also proud to announce the last generation of our AI technology and our deep CBCT analysis that makes it even more predictable, even more efficient. So you can actually expect zero refinements for most of your cases, even complex cases. So now you can actually, as I said before, you can finish your cases in 6 appointments. That's the number that we have in practice of our doctors, and the results are proven to be amazing. So our main goal is actually to show you the future. We're like iPhone of orthodontics. We're aiming to make it efficient and time and cost efficient mostly. So once again, you can see more patients. You can allocate your time in a more efficient way. Well, everyone knows Dr. William Dabney. He is an orthodontist with 30+ years of practice, and he's going to talk on clinical cases more. And please give him applause and welcome Dr. Dabney.
And with the next event, I'm going to be her boyfriend for life because she's going to pin me. All right, I'd like to welcome everyone here today. And I know we've got probably 15+ people here in the audience. Some are residents, some are treatment coordinators, some are physicians that want to learn more. We've also got a wide variety of people watching this online. So I think total, we probably got 50-55 people. I wish I could see you online because we could find out what you're doing. But just to let you know, the talent here in the room, the Virginia Commonwealth School of Dentistry, Department of Orthodontics, wasn't called that when I was there, but it's probably one of those sought after residencies in the country. They always get some top people. We have got people here from North Carolina. We got people here from Utah sitting in the room. We have people from California. We've got somebody from Dallas, and all over the place. Dr. Esser is here, and she's the head of the research down at the orthodontic program. And she has been in Turkey. She's gone to French school. She's been everywhere and everything. And she's another one of our top-notch leaders. I appreciate y'all coming. I'm just interested in technology. Once you've been doing this for a while, you'll get a little bored if you're fitting that band around that 12-year molar, and you can't quite get it, and you're doing the same thing. Let's try something different. Let's try something different. When I first got in, we were banding almost every tooth, except the incisors, which came out in the 70s, something like that. So be thankful what you've got. Dr. Esser and I can talk about teeth with our hands because, it's got an overbite, and you got this, and you do this, and you do that. And now y'all have got this whole digital world that is so amazing that we didn't have to start with, but we've adopted it very well. I've been a digital orthodontist for not quite 20 years for a variety of people. So let's talk about what we're going to do. How do we solve intrusion? One of the harder things we do in life, intrusion and torque. There I am. So I'm a Virginia boy, born and bred. Ortho up at Fairleigh Dickinson, Northern New Jersey. I've been in private practice forever. Do a lot of cool stuff. but just really excited about educating people and learning more and more about technology and sharing some of that wealth, because the things that you can do on your cell phone, I hate to tell you, when you start having children, which a couple of y'all have children, your 4 and 5-year-olds are so much sharper than y'all are. And so it's just going to keep going. All right, dream vacation. I want to be on the beach. Here's my puppy dog. That's little Scarlet. She's one of 6 different boxers we've had over the course. And what keeps me motivated is the technology. We were treated in the area of a ceph was the most important thing we could do. Oh, we're going to measure this angle, measure that angle. And then my friend David Sarver came in and said, let's start talking about faces. Let's start talking about teeth. Let's do this kind of stuff. But no one said, can you pull the gum back? Oh, look under the curve. Oh, cool. There's a tooth there with a bone around it. Okay. And you couldn't see it until we got into CBCTs very accurately. You could do it with bite wings and the rest of it, but not what we can see today. I got to get some questions, because if you don't, people at home will be bored. They're going to be falling asleep, and they're going to say, Bill Dabney's the most boring person in the world. Can't have that. So the agenda, we're going to talk about intrusion and torque, talk about why roots and bone matter. And you got to remember, the old days, we didn't look below there. We were just looking at the crowns and kind of moving this way and that way. We didn't know if teeth were bumping into each other. There's an orthodontist, I think he's retired now, but he made a fortune because he was going to wake up the tongue, and all the bicuspids are going to magically expand out and out and out. And that's how we're going to get rid of the crowding. And I often wonder later, like, what were those bicuspids doing in the bone? So don't believe everything that I say. Don't believe everything that most of your educators say, although the educators are more honest, and the showmen and the show women out there question them quite thoroughly. We're going to talk about torque, and then the types of intrusion, which is the true torque versus just what we consider torque that's just really tipping. And then we're going to go over some of my clinical cases as well. Okay. All right. Intrusion and torque. And this is something that you can take to your patients when you're doing presentations to them, and they start talking about all this stuff like, well, what's this? What's that? I want Invisalign because Invisalign's the big bully in the room. You have to realize that when Dr. Esser and I were going to school, we were told to go Xerox this, okay? Make a copy of something, go run a Xerox, because that was the brand name at the time. Oh, come on. No, she's much younger. But you think about it, Xerox, you're going to make Xerox, and that's a copy, and everybody knows that kind of stuff, but you have to get through that. In the 1980s, 85% of the cars made in the world were made in Detroit. Now Detroit has, I think, 23% of the market, but they're Ford. Yes, your clear aligner trays, generic is Invisalign, and they've done a nice job for 25 years, but you need to explain that that's then, they still practice, but there's some alternatives, and there's some very forward-thinking people who have come up with better ideas. And Invisalign continues to improve. I'm not here to badmouth them at all. But when you start seeing what a CBCT can offer and what this artificial intelligence can offer, it's just mind-blowing. So we'll talk about my attempts at torque and intrusion. Okay, here's one real easy. Class 2 Div 2 that we see a lot of. On the right, it's the cartoon movie that shows these teeth getting straight in a hurry. But you can get an idea in different views as to what we're actually doing at the time and what's going through. You're getting some simultaneous expansion and retraction and torquing. And you can see this over and over again. Okay, without some of these products that 3D Predict has come out with, the traditional way to do some of the intrusion was intrusion arches, burst mechanics, which y'all have had to study, read about. You may or may not use them, but I still use this occasionally on some bracket cases. But you put that intrusion arch in, you do all these auxiliaries, and then, if you want to, you can go big time, I placed a TAD today. How many of y'all placed TADs? Aren't y'all cool? Don't you feel cool? You went home and told your spouse, I placed a TAD today. I placed a TAD today. I'm so, I remember it because I went home and told my mother I did a root canal. And she was like, oh, a root canal? What's that? But no, it's cool to do when you see these things and you need to build your repertoire, but examine everything and question everything. Okay, with skeletal anchorage, this is the up and over elastic, bootstrap elastics on the right with Invisalign. Okay, traditional torque, y'all know all about the brackets. Now they're printing 3D printed brackets that everybody's familiar with. Everybody familiar with Light Force? Who's the inventor of Light Force, or who started? You know his name, Alfred Griffin. My claim to fame is Alfred's mother and father were my dental school classmates. So I've known Alfred since before he was born, but you see it. He's done the system, does a great system. On the right is like an Atlanta torquing spring. You got your torque pliers. And this one, I think this came out of my collection. This is a beg setup. Anybody ever heard the beg technique? Yes, no? Yeah, okay. Yeah, great guy in Australia, just developed things, but he used a lot of auxiliaries. And that's actually a beg torquing spring, stage 3 beg archware. And then if you look down below at this curly thing, that's an uprighting spring. So a very versatile type of thing, but everything extra plaque gets in there, if you can believe it, because sometimes our patients don't brush teeth. Okay, roots and bone. The symbolism on here is we see the crowns above the water and below the gums, it's like an iceberg. And so that's why their little cool demo is, or logo rather. Okay, so here's why it matters. You've got a tooth and we want to torque it, and we'd like to torque it back into bone, not out of bone. And that's some true torque that we added in. It made that tooth healthier long term. And then on the far right is the video that shows you the thinner bone. As they're torquing back in, they're getting some coverage. We're not making bone, of course, but we're trying to keep it within the bone, keep it in the same alleyway that it started. Okay, this is one thing that was really interesting to me when I first started studying 3D Predict, is they can take the 3D plan, the CBTT, the last step, and compare it 1.5 years later, and the teeth are right in the same place. Very stable kind of system, because we're using all the guidelines on where to position, how to parallel roots, how to keep them within the housing. This is the question that we're all here tonight. Using AI, the system is able to be reprogrammed and reset and reinvented every time they push a patient through. Because AI is just machine learning, repetitive, and they study it and they go see what everything is. There's now a new form of AI that'll start predicting things, but right now it's just saying what's what. But we can get 3 millimeters of anterior intrusion with 3D Predict, which is hard to do with most any system. I like the 2 millimeter posterior intrusion, especially with open bites that are hard to do. I used to do a lot of jaw surgery with the oral surgeons to close down these open bites, and now I have an alternative. It may not be as good as the system that the oral surgeons used, may be better, may not be as good, but patients are a lot more liable to go, oh yeah, let me try that if you can get this better. And that's the other thing when you talk to about some of the younger students is Dr. Esser and her staff and all the part-time professors in there want y'all to do an excellent work. Excellent work, excellent work, excellent work. But sometimes you have to compromise. Now, you don't do it to not tell anybody, but you have to say, this is what we can do. What do you want to do? How much better? Ideally, I'd like to do surgery on you. And, you're not going to do surgery on my jaw, I don't think, because I don't have any other reasons. If I had joint issues, if I had this, if I had, 4 or 5 other things, I'd be dying to get it done. But if you're not in pain, sometimes you can do other things for people. And this is the big thing, without any additional things, without TADs. And again, there's your TADs, up and overs. Any questions so far? Any questions so far? Come on, I told you. Absolutely not. I've been doing 3D Predict for 1.5 years. 2 years, okay. But when I start something new, and I'm a tinkerer, and it keeps my brain going, but I get in and go, oh, look at that. And I saw this case, and lady walked in, she was a bank teller trainer, and her jaw was about this narrow. I mean, just couldn't do anything. And I said, well, what I'd like for you to consider at least is let's go in and let me get your teeth straighter, and then we'll go and talk to the oral surgeon about doing this little procedure that kind of puts a little squiggly line through the middle and kind of pushes things apart, and anything would say surgery. And she said, you're talking about surgery, aren't you? I said, yes, ma'am. Not going to do it. So I said, well, I've got a relatively new product. It's similar to Invisalign, but it's AI based. It's a program that y'all know it's out of Russia. Did you know 3D Predict came out of Russia to start with, and things like that? So we talked, and I said, I know, and I've got this cool 3D X-ray machine. And before, nobody had a CBCT, and I got one about 10 years ago. It's like, ooh, open my eyes to things. And sure, I said, let's measure your bone, let's do this. Let's get a simulation, and we walk through with some of the 3D Predict people. And at one point, it was starting to come out of bone a little bit. And I said, hey, at stage 17, let's look at that. Can we first maybe not rotate it and just intrude it and go this way? And once we get further back, now we're going to rotate it. We kept the tooth and bone. I just took pictures a few days ago, so I'll share those with you. But this lady went from a V shape to a nice rounded arch. And I would have been scared out of my britches to do that with any other clients without thinking, okay, I'm gonna get sued. You know, the periodontics is gonna strip and everything like that. But I'll present that at school one time. And we'll post online too. Yes, ma'am. I'll show you a few that have, and I've got a few that are holdouts. But you can talk to the people at 3D. The first year, I only gave them the hardest cases you could possibly imagine. Cases that were like, I'm not going to do it with, let's try 3D Predict. They did that kind of stuff. But I am getting some to finish in those time frames. And I'll show you one. Now, you can imagine some of your cases, you can look and go, boy, that's a bear. That's going to take a while. But your standard routine kind of things, yeah, I think you can do it with one refinement at most and, you know, some visits. Okay. Various studies that I'm sure y'all could tell me the final results. All the residents here have read these, they've discussed them. Everybody's got a little bit different idea of where the center resistance is, okay? And these are on what I call stock teeth or cartoon teeth. It's different shapes of teeth. That's all the same tooth, but everybody's got a different idea of where the center resistance is, okay? And it was a nice concept when I was a student, but then I just go, okay, center resistance, yeah, I can answer that on the test. But what does it really mean, and how do I find it, and where you do it? With artificial intelligence, now you can find that fairly routinely. But let's look at different tooth shapes. All right, Will Ferrell, The Rock, and I always lose the guy. Kevin Hart. Yeah. Okay. So are they going to have the same center resistance? Yeah, I don't think so. Which one of those people do you want to tackle high? Which one of those people do you want to tackle low? And which one of those people would you like to just run out of the stadium and not even get near them? Okay, so if you're going to hit somebody on a football field, you got to know where to hit them. So they're all going to have different center rotations, but that's what the AI and 3D Predict does for you. Okay, here's bodily movement. You know, in my little brain, when I was in ortho school, I thought if I just took a wire and just went out like this, the teeth were just going to follow. You know, because I'm not a make-believe orthodontist, but I'm a dreamer that any movement that I put in, I'm going to get. It doesn't happen. Okay, but this on the bottom right, you see that we now have control, a little more control, because I got plastic on both sides of the teeth, on top of the teeth. Years ago, one of my reps said that the plastic appliance is like having your hands all the way around the tooth, so you've got more control, which I do believe on that. Okay, let's get into torque for a few minutes. All right, we can create lingual and buccal torque using this system. The idea is the center resistance is found, you put the force system on. Throughout this presentation, you're going to see these little purple things on upper incisors, and those are not attachments. Those are pressure points that's built into the aligner, which is a pretty slick system. And then you can also do bite ramps. So we're trying to think about how to do all this on the right to torque those upper incisors. It's the centrals torque, the lingual torque, buccal torque the other, and how we do it. So we're able to add directions of force using the bite plate, bite guard there, all the bite ramps, and then the torque controllers. And you can get, their studies have shown up to 30 degrees. And just watch that for me. Okay. And this is in 15 months, which is pretty impressive. And I'll show you a movie on something like this too. 3D Predict likes for you to wear these trays 2 weeks at a time to get all the movement, because they're able to do more movement. They're more aggressive in doing the movement. That's so they want you to wear the trays for the 2 weeks. That being said, I have an awful lot of my patients changing them every week, because I'm using a product called dental monitoring, so I'm able to see if they're doing that kind of stuff. We're comparing, we've got like not a true study, but somewhat of a study to say we're going to use 2 weeks on these 10 people with 10 weeks over here. with 1 week trial here and just see what's going to go on. But that's why you'll see some of these trays taking a little bit longer than what you think. But that's 30 trays without any refinements. Okay, now this picture is one that you see the initial at 10 on the 10th tray. You don't see a whole lot going on in the upper incisors, but look how much space that they're creating between the bicuspids and the molars. So they're starting to distalize that. They're starting to widen the posterior segment, and they're also working a little bit on torque. So, for the first half of the trays, you're probably not going to see a lot of movement up front, which is where the patients want it. But you can request to your lab tech, can you at least do a little something on a couple of these teeth so patient can appreciate what they're getting into. And then once they create the room, they start doing the torque, and 28 trays later, now the case just looks fabulous. Okay. Once again, comparing the final step and the post-treatment, and then this video shows the torque going in. And these were anterior root torque was done in 6 trays, not the total treatment, but the root torque was done in 6. One thing that we do like that I appreciate is having an orthodontist review some of the plans. They're not telling you what to do, but they're looking over your shoulder, just like when y'all are in class and in clinic, and the first year residents come by and look, and they ask in the second year, because you're really smart, how about this? They said, well, let's go ask Dr. E, kind of what about this? And you get a group looking over it. My staff does the same thing, and sometimes I'm nodding and going, yeah, I'm talking to Bob, keep everybody happy, and they'll say, have you noticed that one tooth? And that's what the orthodontist and their staff will do. Is, doctor, please review the plan, especially the upper right quadrant. So you've got somebody else doing it. That's part of the team practice that they preach. Another clear aligner company has talked all of us into refinements, and they're all accepted. They're expected and respected, so that, oh yeah, just do another refinement, do another refinement, do another refinement, do another refinement. Your patients will get tired of that. There's a lot of plastic being wasted. And so what we want to do is get it right as close as we can the first time. And if you can practice that, it'll make life much easier on you. All right, intrusion. Once again, we're using force vectors, center resistance, and using the bite ramps to help intrude everything for you. And on the right, you see a nice movie of all the movements we're working on. And 3D Predict does allow you to do multiple movements within one tray, where some other appliances, sometimes you can restrict it to do one movement in the next 5 trays, then you switch over and you do this, do that. They're able to do multiple movements in multiple directions. Okay, this is one that somebody had a hard time considering. This was, how are we going to use posterior dentition to anchor it, to use as anchorage? We're moving the upper 6 teeth, intruding those. The upper teeth, the molars and bicuspids we're using as a holding pattern. Some clear aligner companies scallop their trays for comfort. Okay, 3D Predict has found that if they use a straight cut and they include some of the gingival tissue, that they will actually get better tooth movement by incorporating that. Okay, this is some posterior intrusion, and what they've done is, you can see they've set up the bicuspids first, and then once they do that, then they can start getting some posterior intrusion as well. But once again, no rubber bands, no mini screws, nothing that you're asking for the patient except to wear these silly trays. One thing I will say about 3D Predict, when you start to order your cases, they send a plan out and they say, we're going to have you 30 stages. We're going to do IPR at stage 10. We're going to change attachments from vertical to horizontal at stage 16. They're working on something on our behalf that sometimes they would change attachments at stage 14 on some teeth, and at stage 18 the next time, and stage 20 the next time. It's like, no, we got to clear all that stuff up. So when your doc's doing his plans, make sure he looks at that little plan to say, is this going to go in the clinic? Because it's all got to fit in the clinic. Okay, this is what I referenced before. You can do simultaneous movements. And we are seeing less treatment time. We're using 3D Predict. It's up to this limited number of people I have. And I've got 100 cases, maybe, I don't know. I'd have to look. All right, this is the one we showed in 6 trays, how much nice intrusion you can get and torque. I think this is my case that we finished in 7 months and 3 visits. And, y'all are lucky at school. You don't have to talk finances, I don't think, to the patients or anything. Did somebody else do that? No finances. Yes, it doesn't really matter. Yeah, if somebody over here does. And I felt bad because I treated Diane in 7 months, saw her 3 times, and I was really going to refund money. And I have done that before because I'm guilty. I'm a pleaser, in case you haven't figured that out. Okay. But she came in, I said, what do you think about finishing this? She says, God, this is great. All my other friends are in product X and they've had theirs on for 27 months. I love it. I'm so happy I did this. Okay. So sometimes you listen to the patients and their families and you'll learn what's important to them. So we had some nice torque, got some intrusion, and then intrusion of the lower interiors. Yes, ma'am. Did I follow up with patient finish early for? Oh yeah, we do that. And then
let the teeth breathe too soon. Usually we have stability.
exactly. And so that's why long-term retention. Yeah, definitely. I keep them in 20 to 24-hour day retention for 3 to 6 months. And then we slowly start cutting them back. And I will tell them, hey, we did this. We're not moving teeth any faster. We're just more precise. Okay. So we're not rushing the treatment through, but we are more precise. But you got to be able to lock them in place. Not so far, but I do. You need me to put that on? You can hear, okay. But we do stress long-term retention. And on these, majority of them that are adults, we're trying to get a new CBCT about a year to 1.5 years afterwards to make sure that what I'm thinking is true. Because just because I say it doesn't mean it's true. My wife, who was my girlfriend for 5, 6 years before we've been married 40 years, will tell you, just because Billy Bob says it might be something made up. Yeah, this is the girl. So he got some nice distalization, nice alignment. No, it did require some IPR. Yes, yes, yeah. Because if you take those teeth, as you well know, and try to push them out this way and that way, then they're not as stable as what we've seen before. And you definitely need the IPR on a lot of cases.
I thought, yeah, okay.
Yeah, it's like the story we tell everybody. We were born with daddy's teeth and mama's jaw. And
Oh, yeah.
okay, and then luckily we've got some great support people. When I say we, I don't work for 3D Predict. I just like their product. But luckily, as doctors, we've got great support people. And if you want them to overlay your plan from where you are with what they plan, they'll be able to do this kind of basically heat map type of thing to see what kind of movement we really got, what didn't we get. And then they'll take all these measurements, because I'm not going to get down with a caliper and tell you that I got 3 millimeters of whatever. I can look at a result and say it looks good. But yet they'll measure it for you and you can ask them anything, and they're very, very helpful. Okay. So that's a very good quality intrusion within 6 months. This is one that you can talk to some of your prosthodontists and some of the general dentists that are doing some things. As you can see, the bite on the right is collapsed. Somebody lost a crown and it didn't hurt, so they didn't do anything about it. 3 years later, it started hurting and they went to fix it. And it's like, you can't do a crown where there's no room. So they were able to intrude the upper right posterior segment, intrude some of the lower molars to give them more room so they could do the crown bridge. And again, are you going to try as a dentist to restore that and give a halfway decent product, if that? Or are you going to say, we really need to do this? I've got a predictable thing. It's going to take 6 months, but it's going to be a long-term success. Quick break for questions. Anybody going on?
Have you done any cases up to 2 millimeters of posterior intrusion? That's a lot.
That's a lot.
Like even for a tad, that's pushing it.
Yeah, I haven't measured, but I know I've gotten a millimeter and a half. Yeah, because I haven't used anything else. The bite closed down very nicely. I think there's for every millimeter of intrusion, you get 3 millimeters of kind of okay. So yeah, I'm seeing that kind of close down. Very, very special system. If you look at their attachments, there are a whole bunch of different attachment styles, and they have got that through artificial intelligence, and they will say, if you're going to expect that intrusion, you better do an attachment this wide and this deep and this everything to be able to control it. And these are their studies, so, you know.
Have you ever had a patient who just refused to have attachments on the interior teeth because they just aesthetics, you know, they're like, oh, all of those.
I have, and I try to explain to them, it's like you're trying to go in and have your appendix removed, and I can't use a sharp scalpel because you don't want a scar right here for your bikini. Okay. Now, that being said, I will say, can we not do it the first 6 months and see what we can get? And then if I need it, and you'll see you're falling behind, would you consider that? And then I've also been known to put some attachments on the lingual of some of the upper incisors. Yeah, and just, I mean, Dr. Bird is very smart. And if he uses his clinical education and knows his mechanics, which he does, and all this kind of stuff, you know, I'm putting a force on the tooth. Why do I have to put it here just because it's where we put a brace? Can I put it on the side of the tooth? Can I do this? Can I? And so some types of things you can do, and you have to experiment with it. And then the patient goes, well, I feel that in my tongue, you know. Too bad. I don't know what to tell you, but or you can really draw out the treatment and say, great, we'll have you wear these things 3 or 4 weeks at a time. Your treatment will be 3 or 4 years without attachments because we need some extra help. And which path do you want to go down?
Right.
You know, I tell everybody, they're the boss. I'm the contractor, and my staff are some subcontractors. Tell me what kind of house you want to design, and I can build that thing. But there's some restrictions. You want to go to the county and get a permit. You got to do this. Oh, you want me to do it without a permit? No, I'm not going to risk my license. But you can explain that with that, that's the best care. But we could hold off. Do you have a wedding that you're thinking with that? Sure. Come in. I'll take all the attachments off. Won't charge anything. And 3 months later, we'll get started with attachments again. There are ways around it, but they do object. First 50 cases I did with Invisalign, girl came in. She wanted her teeth straightened. I was too stupid not to see it. And I'll explain that part. Calls me and tells me, I don't like these warts you put on my teeth. She says, when I'm putting on my makeup, I use a makeup mirror that's magnified. And when I look this way and I see the mirror behind me and the one up here and the one here, and it looks like a wart, I want it off. I took it off. Then later, about 3 months later, we realized she was going through a messy divorce and she just couldn't handle anything. So you got to get to know your patients. But yeah, you bring it up, we show them, look at this, and someone comes, I don't know. I try to stage my attachments a little later in treatment to when they're used to having trays, they're used to having a bump here on the side. All right, this is my dear friend Jackie, that I was ready to hand her $1,000 check because she finished too fast. Yeah, you feel guilty taking somebody's money when you didn't work very hard. But you're using your brain, you're using technology, you're using a lot of things. And so when I asked her about how she felt, she was ecstatic. But yeah, I mean, it's not a hard case. It's one of those straightforward that we see every day. But those are the ones you're asking, are we seeing them in 7 to 9 months or 7 to 2, in 3 visits? And if you do, and I'll show you a little bit later, that the students won't care much about that, but some in the audience and some virtually do a revenue per appointment progression, and you'll see that with bracket patients, they're running about $200 to $300 when you divide it out and do the formula by a guy down in North Carolina. Who's the business guy in North Carolina? Not John McGill and that bunch. Blair and who? Benson. Yeah, Benson will tell you. And he studies all this kind of stuff, and he'll say, you know, the average brace patient is $200 to $300. You know, liners are $300 or $400. You know, I've had cases that I've earned $800 to $900 per visit with these systems, but I'm putting in the time. I'm doing this, and the people come in and say, well, how can you do this same thing? It's just you're paying for my time. You don't have to come in as often, you know. So that's good for the moms. I can see you virtually because I use a product called dental monitoring. We explain everything. They're like, this is so great. You know, you don't have to fit bands for expanders anymore. That's almost cheating. You did fit bands. You're old enough to fit bands, Dr. Esser. Then you bring them in, you put spacers in, which hurts like crazy. Then you bring them in and you fit bands and you put this mush in their mouth and they're throwing up. And then you finally get them in and you're wasting mama's time because all these moms, majority of my patients, moms bring them in. You're wasting their time. And, ask your spouse how long it takes to get to the office and back and the travel time. And hey, could you work from home? Could you do this? Could you be more productive? So the technology is there, but you have to explain it. And anybody who's had an expand in their mouth, they go, oh my God, you're so lucky. And in my office, if you could take an impression on me without me throwing up, you were hired because I throw up like crazy. Right, but I mean, I just think that's a nice case. It's pretty quick and easy. No, just use a trace, distillation. And that's kind of a before and after from dental monitoring. We just kind of the deep bite and then we intrude it and retract it. And again, this is the staff at 3D Predict come in and, rotation 13.5 degrees. I don't care. They just look straight. It's kind of like one of the Supreme Court justices says, I can't tell you what pornography is, but when I see it, I can tell you. Well, once you're practicing long enough, you'll say, that's a beautiful smile you got. I don't know how it happened. I don't know how many degrees I did everything, but I know it when I see it. But this does show the effects of the expansion, and their claims that they're making are true. Okay, so they went through and measured tooth by tooth by tooth, said how many steps it took to take this, how much to retract, how much to do this. So it gives you an idea. And this is what I wish other companies would publish so that when y'all are studying, you go, how long does it take to close an extraction space? How long does it take to close an extraction space? How many months now that you've finished your program? How many months does it take to close an extraction space? Yeah, depends on patients, and but it depends on how severely crowded they are too. But those are things that we take for granted, or we just after a while you get lazy, you don't measure. But you should have some ideas about, oh, I see that I've got to move that 3 millimeters. That's going to take 9 steps, and then I've got to get some torque and an intrusion. That's going to take 6 steps. Now I'm at 16, and you start planning it out. And if you're not doing that with your cases at school, you ought to be predicting where you want to be in 4 to 6 visits. And then go, oh, you know what? I wasn't anywhere near that. Or, oh, God, that happened so fast. It was a night on wire. But you start seeing it, it's ingrained in your head. But these are some nice studies. And they're not true studies like Dr. Esser likes to do, that she proves at the point everything's cleared up by the clinical review board and that kind of stuff. But just in your mind, it doesn't have to be every case. But on one of these cases, like, that you really like the patient. I don't know. That's a good question. Let's measure it every time you come in. And then you start getting the feel for general things. Who's married in here? How many days, weeks, months did you date your spouse before y'all got married?
5 years.
Okay.
Per year.
Yeah. And it takes a while to learn this kind of stuff. It took me 6 years and a threat that my wife was going to move to California and I wasn't invited, but we were just dating. But it takes a while and everybody's a little bit different, but you need to start looking at some of these things. So when a patient asks you, you can give them a somewhat professional idea of how long does it take to close the extraction space. I don't know, a couple months. And here we got some distalization of the canines in 15 stages using their product, 30 weeks, 7 or 8 months. Rotations are some of the toughest things you can do in a plastic. But again, take and break down a couple of your cases and see what's going on. Here you can see the anterior torque and the expansion. And you can get views with this product that you can't get from anywhere else. I've never been able to look at the bottom of the root and look up and see what's going on. Okay, they broke that out of a CBCT, of course, but they're able to show all the movement and no root collisions. And now we know using this appliance, you can get a couple millimeters of expansion in the lower premolars fairly quickly because we want to upright teeth over bone. We're not just going to wake up the tongue. But all this is through AI to continue to improve. It's just not some smart computer guy or lady that put this together, because there are a lot of those that's 3D predict, but they're actually using AI and running these formulas over and over and over again to see what's going on. Oh, and they've recently partnered with Google Analytics. And in fact, right now, the president of the company, the CEO, is out in California at Google headquarters, and she's working on special projects for them. When our sports medicine doctor over here, you start looking at the best way to exercise your patients in recovery, AI is going to be there, and you're going to be able to predict it and do in your brain, how long does it take to get my elbow back to shape once I've been playing pickleball too much or something fishing. And you've got some studies, and now with AI, they can predict it real nicely, and you can quote those, and you look like a wonder king in mama's heart. Because she's so proud of her son. They just recently moved back from Atlanta, which is great. And again, different views, different folks. All right, the heat map is there. The red is minimal bone. Dr. Esser, how much bone do we not see on CBCTs that's actually there? Yeah, I mean, sometimes you'll see a root coming through, and I've been told, I don't know anything about, but there's still some root there, a root substructure, and I think it's within 200 microns or something.
I mean, sometimes there's controversy in the literature. Sometimes it's said that CBCTs are not that good to figure out the exact bone thickness.
Repeat that just for the
I
audience.
just said that CBCT studies show that the information is controversial. Sometimes it is really not reliable to determine the thickness of the bone through CBCT.
Exactly. It's better than nothing, but it's not an absolute.
Exactly.
But I've yet to have a patient allow me to do a flap and go, let's just see what's in there, you know. But there are some cool cadaver studies. But, yeah. All right, how are we doing on time? I have no clue. Good. Okay. This is the part of people who are out in private practice and working with some smart doctors out in Chester and out in the West End and stuff. Is to you, because you're not as busy right now, and you'll say, I'd like to do a study on our last 10 to 20 aligner finishes and see what's it costing us, what are we earning, and how many refinements we're going to do. Have y'all ever done that in Dr. Bird's office? Just take the last 10, 20, you pick the number, and look at your braces patients and count the number of appointments from start to finish. Leave out the emergencies, that's the staff's fault. Do the same thing with your aligner patients, and then see which one is your less visits. What are you charging for them? And what I tell myself, and I think this is brilliant because I came up with it, is the first appointment, no matter what you do, you've got to get started. Okay, you got to put braces on, you got to put aligners in, or something like that. The past studies have shown if you take transfer cases, 28% of your fee is earned with the first visit. Okay, then you got to take the braces off or attachments off and give retainer. That's worth 10 or 12%. So 40% of your case fee is decided. So how are you going to do the other 60% in your case fee? Do you want to do it in 20 appointments? Do you want to do it in 10 appointments? Do you want to do it in 3 appointments? Because that's your revenue per visit. So just kind of go look at it and check with your dad. He's an orthodontist. And it's something that I hadn't thought about. And this has been going on 10, 15 years of my idea. But you count how many refinements. The 3D Predict is averaging less than 1 refinement. By other aligner companies are 2.5. My 3D Predict, because I'm picky, I'm still doing a refinement. But the patient visits have cut down. And we're seeing some nice revenue per visit. And then if you're not using Gauge, when you get out in private practice, you ought to look at Gauge. They're wonderful reporting for statistics on new patients, for how many appointments you do, and all these other wonderful things that unfortunately we have to think about. All right, AI is coming, it's overwhelming. We can use movements. This is their software. You can click on a tooth and move it in any direction you want. You can either do it on the table on the left, where you can just click button to go 1 or 2 degrees at a time, or you can twist and turn and play the video games. How many of y'all are good at video games where you could do that controller and you race around the tracks and that kind of stuff? All y'all perfect at that, right? I cannot get out of a turn and I just keep spinning and spinning because I can't figure out how to do that controller. But this is what you can do here. So you can pick your poison. You can either do it with your controller and spin it around this way, or if you're old fashioned, you can click one button at a time. On the right are the different views that you can get. There's one up there you can put a grid on. You can see the two size table. You can talk about how much IPR you want to do, attachments, and then you can also see bone or whatever. And everybody's invited to my office anytime they're in Richmond to come out and hang out and just go through cases because they're fun to watch and see. And we all learn. All right. This is Miss Sasha's contact information. She'll be happy to come and demo it all for you. And I think, Sasha, there should be one more. Yeah, there's your scheduled demo and to get your CE credit. But I'm gonna turn this back over to Miss Sasha. And I'm gonna say das vidanya. Dobre večer, Gaspar.
Other than that, again, you can use your computer and people Dabney, so you can learn more about our company. But I was happy to host you today here. Thank you so much.
You have food and beverage back here. Anybody small like me?